All right, so good evening. My name's Shaheer. I'm a SD4 registrar at King's College Hospital, and I'll be giving a talk on lower limb X-rays, covering basic interpretation and some common pathologies to look out for. So just a brief introduction. We can use X-rays in the lower limb to look for trauma, degenerative joint disease, as well as infection. We can look for fractures, arthritis, soft tissue injuries, and it's just important to have a standardized approach so we can come to a robust diagnosis. So as with any body system interpretation, a systematic approach is good to have so that we don't miss anything, and we have an approach which can be easily translated to other areas. So there's also an ABC approach here, and we'll look at alignment. So is there normal alignment of the joints? So such as this radiograph here of the wrist, which demonstrates normal alignment of the carpal bones, but we can see that there's a break in the distal radius metaphysis, and that so that's our first step, and then we'll go on to the bones, looking for any sort of cortical disruptions, of which you can see here, and any change in density. So you can clearly see the trabecular bone changes in density from the normal to the fractured cleft, which is much lower in density or darker on the X-ray. You can also assess the joints in the cartilage, less so the cartilage, but we can see the joints, the radiocarpal joints, the distal radioulnar joint, and also the carpometacarpal joints as well on this film. So that can give us an idea of any dislocation, any joint degeneration, or just general narrowing. We'd also look at the soft tissue depth. Gives us a good indication of when there's no obvious fracture. We can have a look at whether there's any soft tissue swelling to indicate underlying soft tissue injury. We can't assess for a fine ligamentous or tendinous injury on plain radiograph, but we can get a hint of it or an idea of what might be injured. It's just cut off from the slide here, but we can also look for any extra findings such as surgical screws or fixation, and any incidental findings such as any lesions, which can be either bony or soft tissue. So starting off proximally, and we'll be working our way down. So I'll start off at the hips and the pelvis. So it's important to know the views in radiography before approaching interpretation. So for the hip, generally we do a AP, anterior posterior pelvis, as well as a lateral hip, which is a horizontal beam taken while the patient is lying down. So looking at the common pathologies, working our way proximal to distal, we have different types of neck of femur fractures. So this is what we call a subcapital fracture, which is a fracture within the capsule, and the most proximal form of a neck of femur fracture. And you can see on this AP pelvis, there's a sclerotic line going through the left neck of femur. There's not much displacement, but if we compare it to the right side, which looks relatively uniform and normal, this sclerotic line gives us an idea that there is a fracture here. Coming down, we come to the sort of transcervical, which is also generally intracapsular, but there's a bit more displacement in this radiograph. This is more of a lateral film, or a bit more oblique, which can give us an idea of the degree of displacement and rotation. So the lesser trochanter here is a little bit more prominent, which tells me the femur or the leg is rotated secondary to the transcervical fracture. And then we've got a lower cervical or basicervical fracture, which is also intracapsular. And you can see there's a larger degree of displacement here. We're coming intracapsular, we're coming a little bit pericapsular here, because we can now see that there's a bit more proximal displacement of the femoral shaft on the left side, secondary to this fracture, which is quite obvious. And when you compare to the right side, you can clearly see that the neck of femur is injured, and this is the fracture line. And ideally, and there's quite a bit of proximal displacement. So you'll see limb shortening on that side in a clinical examination. And then we come into the sort of extracapsular hip fractures. So we've got a intertrochanteric fracture, which is usually extending from the greater to the lesser trochanter. And now we've got a degree of proximal displacement of the distal fragment. So when we talk about displacement in fractures, we talk about the distal fragment. And that will result in limb shortening, as well as there is angulation of the distal fragment medially in this case, because the actual femoral head is externally rotated, but the or abducted, and the femoral shaft is medially angulated. The same in the subtrochanteric region. So this is a little bit a bit more distal, a bit more lower down, and there's also a comminution, a fragment of the lesser trochanter, which is the insertion of the iliopsoas tendon. Coming on to dislocation, so the most common dislocation in the hip is the posterior dislocation, and this is usually through the mechanism of a dashboard injury, usually a passenger or a driver in the front seats of a car. This is because of the configuration of the a capsule of the hip, which is most strengthened in a standing position, where the hip is extended. But when you're flexed, then these capsules or these bands are more lax. And if there's a trauma, usually from the front to the knee, then that will push your femoral head backwards and out of socket. Anterior dislocation is much less common. It's usually associated with multiple fractures, especially acetabular fracture. I can't quite clearly see that one here, but this is usually associated with a high velocity trauma. Coming on to joint disease, so we've got two main types of arthritis, which is osteoarthritis and rheumatoid arthritis. I'll briefly go over this. You can see there's quite distinct joint space loss in both cases. The usual pattern is osteoarthritis. The hip, the femoral head is displaced superiorly, and you can see quite marked joint space loss bilaterally, but more so on the right, at the roof of the acetabulum. And then in rheumatoid arthritis, we usually see axial displacement. So the femoral head protrudes inwards into the acetabulum, and then you end up with a phenomenon called protrusio acetabuli, which is basically the femoral head protruding into the acetabulum and into the pelvis. And also related to joint, but more so related to bony pathology, there's avascular necrosis of the hip. And we're basically looking back at the previous example. We want to see, even in a degenerative hip, we want to see a nice rounded regular outline of the femoral head. But when you come into a case of avascular necrosis, there's quite a bit of sclerosis and irregularity of both femoral heads. This can be an idiopathic process in young patients, termed as Perthes disease, but it can be secondary to infection, trauma, and steroid use. So coming down to distally to the femur, usually we, as with most areas, we take of AP and a lateral film, as highlighted here, and generally speaking, we'll get same long bone fracture patterns as we see in other areas. So we can get a transverse fracture. This is a little bit oblique, but that's okay. And we can get a spiral fracture, which is usually as a result of a heavy object or heavy projectile, and then also a comminuted fracture, which is usually the most common in a femur, because it takes a quite substantial force to result in a femoral mid-shaft fracture. So usually these are comminuted fractures, and less commonly transverse and spiral. So coming down to the knee, where there's a whole host of pathologies, but we can just have a look at some common cases. So we've got the standard views, which is the AP and lateral, which is the most common. We can also get, which is not highlighted here, but we can get patella views if we're looking at patellofemoral pathology or a patella fracture, and that is usually a view from above, looking at the patella specifically. So this is a case of a patella fracture where the superior pole of the patella is displaced and retracted superiorly. This is where the distal quadriceps tendon attaches, so that's usually in tension, in an extended position. So that's been displaced, and then there's probably laxity of the tibial tendon, or the patellar tendon distally, and there's probably a further osteochondral fragment there secondary to that fracture. Knee dislocations, so this can be either traumatic or related to trochlear dysplasia, which is basically the groove in which the patella sits is too flat. This is usually seen in young patients, and in cases of patella alta, where the patella sits too high or patella sits too low, and also in young females where the hip angles are disrupted during puberty, and the patella can demonstrate lateral displacement, in which is shown here. So coming on to tibiofemoral joint dislocations, this is usually quite uncommon and related to a very high velocity trauma and related to extensive ligamentous injuries. The third example here is one which is likely related to extensive degeneration and gradual dislocation, but the other two are most likely related to some sort of high impact trauma. So the knee joint is one of the most commonly affected joints in osteoarthritis, and as you can see here, there's joint space loss, there's a marginal osteophyte formation, there's subchondral sclerosis, seen a bit more clearly on this film, and not so clearly seen here. You can get some subchondral cystic change, and plain radiographs gives us quite a good evaluation of knee osteoarthritis, and we can correlate that with clinical symptoms quite well. However, there's a lot of debate in terms of the actual value of repeat imaging and correlating appearances of osteoarthritis with the severity of disease. So just take that with a pinch of salt. So coming a bit more distal into the tibiofibula, same as before, in the femur, we take a APN lateral view to assess for injuries, and we can get different types of fractures depending on where in the tibia or fibula we are. So at the knee joint, we get a specific pattern of fracture called tibial plateau fractures, and this is basically a fracture of either the medial or the lateral tibial condyle, which extend into the knee joint or the tibiofemoral joint. And we've got different fracture patterns which are described in the literature, and they correlate with the mechanism of injury as well as the surgical management which follows. I won't go too much into detail in terms of the different fracture patterns. So coming down into the tibial and fibular shaft fractures, one thing to note, which I didn't cover in the pelvis, or it may have been covered in a different lecture, is the tibia and the fibula act as a ring. So usually when you see a fracture either in the fibula or the tibia, the other bone will demonstrate a fracture or dislocation. It's not quite clearly seen here, but I suspect there's some sort of injury in the distal fibula or the proximal fibula accompanying this oblique tibia fracture. And then also you can see here there's definitely a transverse fractures of both the tibia and fibula. Stress fractures are tricky to spot on plain radiographs, and you really have to correlate with the clinical symptoms and the history, usually from repetitive microtrauma, either from a long distance runner or a gymnast, and you can see here there's evidence of some sort of irregularity at the medial cortex of the mid tibia, which demonstrates a lucent line as well. And there's some increased sclerosis in the trabecular bone in this region, which is suggestive of an underlying bony injury. So coming down distally into the ankle, the views of the ankle are slightly different. So as previously, we do take an anterior, posterior, AP, and lateral views, but we also want to see the ankle mortise, which is the tibia and talus, tibia-talar joint lined up, and we want the X-ray beam to go parallel to the dome of the talus to see that view, and this gives us an idea of whether there's any lateral talar shift in what we call malleolar fractures, as we'll cover here. So there are essentially two malleoli, which is the medial malleoli coming from the tibia and the lateral malleolus coming from the fibula, but we also describe the posterior malleolus, which is the posterior aspect of the distal tibia. And we can see an example of a trimalleolar fracture here. The fibula is just projected behind the tibia. We've got a displacement of the posterior malleolus, and it's less clearly seen, but we can see a fracture of the medial malleolus here as well. And you can see here the value of, this is a little bit oblique and it's not an optimal projection, but you can see that the talus is slightly displaced laterally, which is what we call lateral talar shift, but this is better assessed on a weight-bearing film, and I'm not sure whether this is because it's the label is either cropped out or not available. So we come into a Weber classification when we talk about distal fibular fractures or lateral malleolar fractures, and going from distal to proximal is an ABC classification, and this essentially tells us and the orthopedic surgeons whether the fracture is below the syndesmosis, which is a band of fibrous tissue or ligamentous band between the tibia and distal tibia and fibula, whether it's at the level of the syndesmosis and whether it's above the syndesmosis, and the surgical management will change according to that classification. So coming into the foot, these are usually the standard views which we take, the most important being, well, all three of them are important. So we've got an AP and a lateral, and we also take an oblique view to open up those tarsal bones, which are usually quite overlapping in the foot compared to the carpal bones in the hand, which are less overlapping. So we usually need to take an oblique view to assess those more clearly. Just kind of skipped past that, but looking at the metatarsals, we can quite commonly see stress fractures in runners and long distance runners, and marching band, or like in the military, and they present with this sort of type of stress fracture which we call a march fracture, and you can see there's a early callus formation around the distal shaft or the diaphysis of the fourth metacarpal, and we can also see there's a transverse fracture at the proximal metadiaphysis of, or proximal metadiaphysis of the fifth metacarpal on this side. Sorry, metatarsal. I always get those mixed up. So the calcaneus is notoriously difficult to assess on plain films. This is quite an obvious calcaneus fracture, usually from a jump or a fall from a height, and landing on your heels, and the axial load will usually shatter the calcaneus, which takes the brunt of the force. But usually they're subtle, and you really have to look at the trabecular pattern and the disruption in those trabecular lines to see these clearly. And a word of one thing to note is, usually due to the mechanism where you're landing flush on your heels, the axial force usually projects through the body and into the spine, and it's a good idea when you spot one of these calcaneal fractures to recommend the clinician imaging or assessing clinically for any spinal fractures, particularly around the T11 to L1 region, which can accompany these injuries. Coming on to the joints of the foot, we've got what we call a hallux valgus deformity, which is the large toe metatarsophalangeal joint is angulated beyond a certain angle, and produces this sort of hallux valgus, and this bunions can become quite severe and cause disruption of the remaining toe metatarsophalangeal joints in severe cases, and that's why these are usually surgically managed by a foot and ankle orthopedic surgeon. The foot is a very common area for gout, and usually affecting the first toe. This is quite a extensive and severe case, but usually affecting the first metatarsophalangeal joint, as well as the the interphalangeal joint, and generally speaking, gout demonstrates joint space loss. These punched out subarticular erosions, and these dense gouty tophi overlying the joints, which are a classic hallmark of gout. So just going through a few case scenarios. So starting with scenario one, we've got an 82-year-old woman with a history of osteoporosis presenting after a fall from a standing height, and she's unable to weight bear on her left leg, which is shortened and externally rotated. We'd kind of just go through this image. I think this is similar to the example we did previously. So the X-ray firstly shows there's diffuse a decrease in bone density throughout the pelvis and proximal femora. I can see there's a sclerotic line through the left femoral neck, and there's a slight shortening of the femoral neck compared to the right side. So I would recommend an orthopedic review for fixation. So this would be in keeping with a intracapsular fracture. Great. Oh yeah, it's been some time since I've recommended different orthopedic management, but of course, when we've depending on the demographic of the patient and the degree of displacement of the neck of femur fracture, we would decide between a hemiarthroplasty where only the femoral head is replaced, and a total hip replacement where both the acetabulum and the femoral head are replaced, or a dynamic hip screw, which is generally reserved for extracapsular fractures, which have more bone surface for fixation compared to intracapsular fractures. Coming on to scenario two, we've got a 30-year-old football player twisting his ankle and had a crack and is now unable to weight bear. So you can see here there's it's a nice example of a trimalleolar fracture, as we described previously. There's fracture of the medial malleolus as well as the lateral and posterior malleolus, yeah, so you would recommend an orthopedic review. They would need to ideally assess this with a CT for their operative planning, and from a clinician perspective, I would also examine the joints above and below. So you would examine the foot and also examine the knee carefully. Usually football injuries and twisting injuries are usually accompanied with ligamentous or soft tissue injuries at the knee, including the cruciate ligaments. Yeah, so that's, yeah, the management is the immobilization, analgesia, and orthopedic referral. So in summary, we've covered lower limb x-rays and approaching these with the ABCDE method, which improves our accuracy and gives us an approach to cover all the bases. We've looked at different fracture patterns and dislocations in the pelvis, in the knee and the ankle. We didn't cover it in detail, but look for hidden injuries such as stress fractures. We didn't cover Lisfranc injuries, but that's more of a sort of fracture dislocation pattern involving the base of the metatarsals and the tarsal bones, including the cuneiforms, and we briefly went over further management, including any further imaging required, usually orthopedic referral, who would recommend either conservative or surgical management, and these should align with the national guidance. So yeah, there's a QR code there if you would like to join the WhatsApp group for SynapseUK, which is run by excellent group of medical and dental students. And thank you for having me today.